Okay, sir, we're live now.
Good evening all and a warm welcome to all for the ExRxIndia's and Sri Samraj Health Services Private Limited's presenting for the students by the students web series in association with Pickle Studio, Sairam Academy and Dusat Creations. Today's second topic is respiratory failure. Will be presented by Ms. Sharon D. Silva from St. John's Medical College, Bengaluru. I welcome our ExRx India team members, Dr. Rupesh and Professor Duna Saha. Now I welcome our resource person, Ms. Sharon D. Silva, to present her topic.
Thank you, sir, for the warm welcome. First of all, I would like to thank the ExRx team for providing us this platform. And also, I would like to thank Department HOD, all the teachers and all my classmates who have been there with constant support. So I'm really thankful to them. So the topic for my presentation today is respiratory failure. I'll just share my screen. Sir, is it visible?
Yes.
Not
Yes,
visible, Sharon.
Oh, okay.
It is okay. I cannot see it through.
So our topic today is respiratory failure. So what is respiratory failure? So it is an imbalance of ventilatory requirements to meet the neurocardiorespiratory needs. So in basic terms, we can understand it as it's characterized by reduction in the function of the lungs due to any lung disease or a skeletal or a neuromuscular disease. So lungs fail to oxygenate arterial blood. So this is the type 1 kind of respiratory failure. And in the second type, the muscle fails to prevent the undue CO2 retention. That is the type 2 type of respiratory failure. We're going to discuss this in detail in the further slide. Okay, so there are no absolute diagnostic values as such for the respiratory failure, but PaO2 of less than 8 kilopascal and PaCO2 of greater than 6 kilopascal is considered as the reference. Okay, so the common clinical features seen in respiratory failure are breathlessness, dyspnea, cyanosis, agitation, and the use of accessory muscles. But these are not diagnostic of the condition. So we use oximeters that estimate arterial oxygen saturation either from the finger or earlobe, and they're useful for indicating the hypoxemia. All respiratory compromised patients should have oximetry checked. Unconscious patients should therefore have arterial blood gas analysis as initial assessment. Okay, so to understand respiratory failure, we first need to understand the physiology of it, the physiology behind it. So the respiratory system has two major parts, the lung and the respiratory pump. The lung, it is the gas exchanging organ, and the respiratory pump, it ventilates the lungs. So the respiratory pump consists of the chest wall and the respiratory muscles. So these respiratory muscles are directly connected to the higher centers, that is CNS, and these pathways connect together to the respiratory muscles. So this is the two major parts which are involved. Now we'll see the act of respiration. How does it happen? So it basically occurs in three major steps. First, transfer of oxygen across the alveolus, transfer of oxygen to the tissues, and removal of carbon dioxide from the blood. As you can see in the picture, this is an alveoli. So first, the oxygen is the oxygen diffuses into the red blood cell. As it diffuses, the carbon dioxide diffuses back to the alveoli. So basically here in the capillaries, the red blood cells are getting oxygenated. The alveolar capillary unit of the lungs are primarily where respiration takes place, with exchange of oxygen and carbon dioxide between alveolar gas and blood. Oxygen reversibly binds with hemoglobin after diffusing into the blood. So this is clearly seen in the picture given here. Okay, so we're now going to discuss the type 1 type of respiratory failure, also known as the hypoxemic kind. Okay, So it is basically caused by the intrinsic lung disease. Intrinsic lung disease is the restrictive lung disorder that interferes with the oxygen transfer in the lungs. So here the oxygen transfer is affected. Hypoxemia. Hypoxemia is the key feature that happens in type 1 type of respiratory failure. This is caused due to three main reasons. The first reason is increased right to left shunts. So what is right to left shunt is? Right to left shunt is a cardiac shunt which allows blood to flow from right side of the heart to the left side. So basically there's mixing up of the blood, the oxygenated blood and the deoxygenated blood. So this is basically a congenital disorder. So in type 1 type of respiratory failure, these increase. Second reason is ventilation perfusion mismatch. So to understand what is ventilation perfusion mismatch, V stands for ventilation, that is the air we breathe in. Q stands for perfusion, which is the blood flow. So V by Q ratio is basically the amount of air that reaches the alveoli divided by the blood flow in the capillary in your lungs. So what happens in V by Q mismatch is that either the part of your lung it receives oxygen but there's no blood flow, but if it has blood flow there won't be any oxygen. So this is what is V by Q mismatch. So this occurs in type 1 type of respiratory failure. Third point is functional residual capacity is reduced. So what is functional residual capacity? This is the volume of air present in the lungs at the end of passive expiration. So this is reduced in type 1 type of respiratory failure. So these three are the main reasons behind the type 1 type of respiratory failure. This results in an increased number of under-ventilated lung units. Hypoxemia resulting from V by Q mismatch or diffusion abnormality can easily be corrected with supplemental oxygen. This is in contrast to hypoxemia induced purely by increased shunt. It is refractory to supplemental oxygen. Common causes include acute respiratory distress syndrome or ARDS. So we can see in this picture, the common signs and symptoms we see in this picture is tachypnea, dyspnea, retractions, hypoxia, tachycardia, and the major causes because the reason behind it are trauma, pulmonary infection, any aspiration and shock, fat emboli, and sepsis. So these are the various causes of ARDS. Clinical features seen in type 1 type of respiratory failure are hypoxia, where there's no enough oxygen that makes up to the cells and tissues of the body. Hypocarbia, it's the state of reduced CO2 in the blood. Tachypnea, that is increased respiratory rate, and small tidal volumes. Now we'll see the type 2 type of respiratory failure, also the hypercapnia type or the ventilatory respiratory failure. So this is caused by failure of respiratory pump. We saw it before what the respiratory pump is. So here there's a failure of the respiratory pump where the amount of CO2 excreted is less than what is produced by metabolism. So the amount of CO2 which is excreted is less. So basically there is increase in PaCO2 levels. Hypoventilation. Hypoventilation results from a reduced respiratory effort. Individuals are unable to cough effectively or sigh. The risk of alveolar collapse, secretion retention, and secondary infection is further increased. Arterial carbon dioxide pressure PaCO2 is greater than 50 mmHg. It is commonly caused by myasthenia gravis, head injuries, polyneuropathies, muscular dystrophy, kyphoscoliosis, flail chest, obesity, hyperventilation syndrome, advanced chronic bronchitis, and emphysema. Common clinical features that are seen typically in type 2 type of respiratory failure are hypercarbia, that is buildup of CO2 in the bloodstream, hypoxia, reduced respiratory rate or tidal volume, and mixed respiratory failure. Now we're going to see the type 3 type of respiratory failure. It is not as common as the type 1 and the type 2 type. So this basically occurs in the perioperative phase because the factors that reduce the FRC combine with the causes of increased closing volume to produce atelectasis. So basically the functional residual capacity of the individual decreases. Perioperative phase is the phase before a surgery. So it is commonly caused by inadequate post-operative analgesia, obesity, ascites, and excessive airway secretions. The type 4 type of respiratory failure, it results from hypoperfusion of respiratory muscles in patients in shock. Patients are usually intubated and ventilated in process of resuscitation for shock. It is commonly caused by cardiogenic, septic, and hypovolemic shock. Now we'll see acute and chronic respiratory failure. So acute respiratory failure, it develops over minutes to hours, and there's no time for renal compensation. pH is less than 7.3, whereas in chronic respiratory failure, it develops over several days, allowing time for renal compensation, and there's an increase in bicarbonate concentration. pH is only slightly decreased. Now we'll see the etiology of the respiratory failure. First one is the central nervous system dysfunction. So in basically there are like drug overdose or brainstem lesion in this. Second one is the peripheral nervous system dysfunction. It includes myasthenia gravis, GBS syndrome. Third is chest wall dysfunction like kyphoscoliosis, obesity. Then airways dysfunction as seen as in like COPD, asthma. Then we have alveolar dysfunction seen in pulmonary edema and pneumonia. Then we have pulmonary circulation dysfunction, which is seen in pulmonary embolism and pulmonary hypertension. Now, the common clinical presentations seen in all the type of respiratory failure are dyspnea, tachypnea, restlessness, confusion, anxiety, central cyanosis, tachycardia, pulmonary hypertension, and loss of consciousness. Okay, so now we go to the physical findings. So hypotension, it is usually with sign of like poor perfusion suggests that there is a severe sepsis. Hypertension, because with signs of poor perfusion, it suggests cardiogenic pulmonary edema. Wheeze and stridor, they suggest airway obstruction. Tachycardia and arrhythmias, they are cause of cardiogenic pulmonary edema. Then we have elevated jugular venous pressure. It suggests right ventricular dysfunction. Then we have respiratory rate less than 12 beats per minute and paradoxical respiratory motion. Now the lab investigations, arterial blood gases. So these are used to identify the respiratory failure. So first one is the arterial blood gases. It measures the oxygen and the carbon dioxide in the blood. Then we have full blood count. It may indicate if there's any anemia, which may contribute to hypoxia. Then third one is the renal function test. It indicates obstruction, restriction, and gas diffusion abnormalities. Then we have pulmonary function. Then we have the electrocardiography, ECG, which determines if respiratory failure is from a cardiovascular cause. Then we have chest radiography, which reveals the cause of respiratory failure. And then we have the last one, the thyroid function test. Hypothyroidism may cause chronic hypercapnic respiratory failure. Now we'll see the complications of respiratory failure. The first one is pulmonary embolism, pulmonary fibrosis, hypertension, hemorrhage, gastric distension, infections such as nosocomial pneumonia, UTI, acute renal failure, and malnutrition and complications. Now we'll see the management of respiratory failure. First one is inhaled medications. So medicines can be administered either through an inhaler device or through a nebulizer machine, which can help to keep the airways open and allows the lung to pick up more oxygen. Oral medications can help to prevent the worsening of the respiratory failure, and it helps to prevent worsening of lung function in the long run. Third one is the oxygen therapy. It is administered using a mask or a pronged tube, and it is just placed under the nose. The prongs deliver the oxygen directly into the nose. So it may be administered during sleep or during exercise, or it may be administered at all times if needed. Then we have tracheostomy. So it involves surgically creating a hole in the front of your neck into a windpipe. So a tube called a tracheostomy is put into the hole to improve the breathing. Then we have non-invasive positive pressure ventilation. So it is a non-invasive treatment that helps to keep the airways open while the person sleeps. NPPV involves wearing a mask that creates mild air pressure to keep the airways open. Last one is fluids. Having the correct amount of fluid in the body supports proper blood flow and transportation of nutrition throughout the body without causing fluid to build up in the lungs. So fluid can be given intravenously to ensure that there's the right, it's like going to the right amount is going to the patient. Then we'll see the physiotherapy management of respiratory failure. First one, positioning. So to position a patient's body in a specific body position is aimed at improving the ventilation perfusion mismatch, and it helps in mucociliary clearance, improves the aeration. So the first position here mentioned is prone position. So the prone position helps to improve V by Q matching and redistribute edema and increase FRC. Second one is side lying with affected lung uppermost to improve aeration through increased lung volumes in patients with unilateral lung disease. Then third one we have semi-recumbent. So it is helped to prevent any GI reflux and aspiration. Fourth one is upright position. This helps to improve lung volume and decrease the work of breathing. The second one we have here is postural drainage. So we use the gravitational effects to facilitate the mucociliary clearance in this. Third one is suction. It is basically used for clearing the secretions when the patient cannot do independently. So this suction is used. Then we have manual hyperinflation. So it aims to re-inflate atelectatic areas of the lung to improve the pulmonary compliance and facilitate the clearance of pulmonary secretions. Then we have active cycle of breathing technique and manual techniques such as shaking and vibration to facilitate mucus clearance. Next one is limb exercises. Passive, active assisted, active exercises may optimize oxygen transport and reduce the effects of immobility. Then we have inspiration muscle training. So it helps to improve the inspiratory muscle strength and it facilitates weaning from the mechanical ventilator. So this is useful while we have to wean a patient from a mechanical ventilator. The last one is early mobilization. So this early mobilization helps to improve the function and the mobility and overall the quality of life. Thank you.
Thank you, Sharon. Really very nice presentation. And the way the slide looks also very attractive. Different colors and highlighting specific words. Very nice presentation. Thank you so much. I thank Dr. Annie Thomas and all the professors from St. John's for supporting the students who contribute for the students by the student web series. And I thank all your friends who supported. I thank my ExRxIndia team members. And I thank Kalpana madam who are constantly supporting us and encouraging students also. Thank you everyone. Bye-bye. We will meet in the next topic. Kindly join us, Sharon.
Yes, I will do surely.